Since December, when the novel coronavirus was discovered in Wuhan, China, tens of thousands of people have been infected and 2,000 people have died. While the United States has seen only a comparable handful of cases, CDC experts are preparing for an outbreak in America. The AHA continues to work closely with the CDC, HHS, and other partners to keep hospitals and health systems informed on the latest resources and news. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hetterly, Senior Writer for AHA. Dr. Colleen Kraft is Associate Professor in the Department of Medicine Division of Infectious Diseases at Emory University, as well as an Assistant Professor in the Department of Pathology at Emory School of Medicine. She was a physician leader during the West African Ebola outbreak and cared for and treated patients with that disease. Today, Dr. Kraft talks with Akin Demehin, Director of Quality Policy for the American Hospital Association, about her experience, what this outbreak could look like, and how hospitals can prepare. And now to Akin.
Well, Dr. Kraft, thanks so much for taking the time to join us this afternoon. To start us off, can you talk about the role that you played in the 2014 and 2015 Ebola outbreak in West Africa?
Yeah, thanks. The role that I played at Emory University Hospital during the 2013 and 2016 outbreak was as one of the infectious disease physicians on the clinical team that cared for these patients in the biocontainment unit in Emory University Hospital. Also, because of my laboratory background, since I also work in our clinical laboratories, I also served as a liaison between the clinicians and the laboratorians for just coordinating testing and samples for our patients.
Terrific. And what lessons do you think the response team at Emory learned, as well as the broader U.S. healthcare system, with respect to that outbreak?
Well, how much time do we have to talk about it?
Just a couple of
We're still learning lessons.
Okay. Impressions are fine, but take as much time as you need.
No, I'm just being funny. I think we learned a lot. I think the things that really remain for me as most important that I try to use as aspects of how I make decisions today, even with this coronavirus outbreak, is the concept of teams and of listening to all members of the team. So that was one thing that was really modeled for us by Dr. Bruce Ribner at Emory Hospital, was we had quite a flat hierarchy when we were making decisions. So we really listened to sort of everybody's concerns and then made the decision together so that everybody would feel comfortable. I think it's also just how I approach everything subsequently. We need to have the right people in the room. It needs to be multidisciplinary. And, you know, the more people that can give input into a situation, especially with our experience at Emory, it's really made us nimble to make decisions about different things that come up. I mean, things come up all the time. We have measles, pandemic flu, et cetera. And so I think, you know, it helps us to be able to make good decisions and good choices in the future as continuing on in that team mentality. Another thing that we learned was, you know, sort of how to care for people safely. I think if you would have told me 10 years ago that I would be really focused on healthcare worker safety and preparedness, I would have said that was sort of a boring topic. But when you encounter something that could be transmitted to you that is potentially fatal, I think it puts into perspective sort of everything that we do on a day-to-day basis in the hospital, and sort of how inattentive we can be just in our personal lives to our own vulnerabilities to transmission of diseases. And so I think healthcare worker protection, thinking about things like our behavior, our environment in that setting, and also you know, what sort of controls we have in place and what kind of support we have for our healthcare workers so that we can take the best care of patients that we possibly can.
All of those are incredibly important lessons. And you started to allude to this already, but you know, Ebola is a different animal compared to the current outbreak of the novel coronavirus. Could you describe the similarities and differences between those two and what it means for containing the novel coronavirus outbreak, and especially with respect to caring for patients in healthcare facilities and protecting healthcare workers?
I have lots of opinion on this, so I should probably say up front, these opinions do not necessarily represent Emory University Hospital. We're trying to figure out how we prepare ourselves to be ready, either for the person that walks in from the street that has coronavirus or the person that may be transported to us from a different location. So Ebola and coronavirus to me are very different. Obviously, their modes of spread of transmission are very different. A respiratory pathogen always has the ability to both transmit via air and droplets, but also has the ability to transmit via fomites. And so if I break down that word, I really think of that word as surfaces. So when I'm in an airplane, for instance, I think about who's the person that sneezed on this, tray on the airplane, or who has touched this elevator button after wiping their nose. We encounter viruses on surfaces all day long, but we sort of ignore them because the worst thing they may do to us is a cold. But if we think about getting a worse virus, such as coronavirus, from those surfaces, I think it makes us pause and wonder if we should be doing something different to protect ourselves and how we should be behaving sort of with surfaces and in different environments. Ebola is spread really through the body fluids being in contact with a mucous membrane of some sort. I think we're still trying to figure out exactly how it's spread person to person. Obviously, lots of contact and intimate contact allows it to spread. It also causes a sepsis syndrome and is has a high mortality rate. Currently in the outbreak in the Democratic Republic of the Congo, that mortality rate is almost 2/3, which is significantly higher than the West Africa Ebola outbreak. So the differences between this is one has a larger spectrum of disease, which would be the novel coronavirus, where people can be asymptomatic, people can be symptomatic but be fine and be at home, or people may have severe disease, and we're seeing that at the extremes of age as well as in people that are sick at baseline. So that is a little bit different of something to acquire. It's more like a bad influenza year, and I think there's a little bit more acceptability of that method of acquisition. We sort of already are having that all the time. But I think where we need to be concerned, and I think where we're appropriately thinking about, is this looks like it's a virus that causes lower respiratory tract disease. And so while many of us get bacterial pneumonias after we get cold viruses, this is potentially a cold virus that can go into your lungs, for which we have no treatment. And so I think that's really where we're distinguishing this from other coronaviruses that cause the common cold. So in terms of the difference between the two, the transmission is different. The fatality rate is much higher with Ebola. And I would also argue that Ebola, because it's not endemic in the United States, should be contained wherever it's found. That occurs also in Africa, so it's not something that we would ever house in the community. I do think people that are unwell from the coronavirus but not sick enough to be in hospital, I think putting them in the hospital allows us potential risks. And so we are even today working with our local state health department to figure out how we can have a private-public partnership to be able to address the issues of many more patients than we had with Ebola, right? We had a total of 4 patients. But if we were to if coronavirus was to spread more in the United States, we have the potential of having many more. And so how do we safely take care of those patients? How do we keep them at home if they don't need to be in the hospital? And how do we, kind of triage all of that to prevent transmission in the community and in the hospitals?
The range of issues that you're grappling with here is really, really interesting to hear about. Let me shift gears and talk a little bit more specifically about the novel coronavirus. What do you think hospitals can do now to prepare for the possibility that the novel coronavirus becomes widespread in the U.S.?
Well, one of my phrases that I like to say, that's not my phrase, I'm sure I took it from somewhere, is don't waste the crisis, right? You have people's attention, do training for infection prevention and control, remind people about hand washing, remind people about their own hygiene and cough etiquette to be able to reinforce the lessons we should be doing during respiratory season. We should not be coughing on other people. We should not be touching our faces after we've touched dirty surfaces. Just in general, that's a good principle. And so I think just using this public health concern to just get the preparedness sort of teams back sort of focused on what they can do. I think it's a good exercise. If it doesn't become widespread in the United States, that will be wonderful. But we want to have said, you know what, this allowed us to be more robustly ready in case we have a really bad flu season, in case there's a pandemic flu, in case there's more measles. So we should be doing the CDC's guidelines, identify, isolate, inform. You should be doing that over and over again. So you identify if the person's at risk by a travel history, you isolate them, meaning you put a mask on them, and then you wait to see how you can evaluate them, and then you inform others, such as the health department or the hospital setting or the clinic, that you have an individual that you're concerned may have coronavirus or another infectious disease that's very contagious. And so it's a good time to reinforce, retrain, and practice all those measures, because it's not going to be coronavirus necessarily in the future, but there's many other things that can be prevented the same way.
Really important takeaways for the field, especially the notion of drawing upon the tools that we have already to combat diseases like this one. One of the things that we hear about from healthcare providers is that they are worried that the novel coronavirus in China may be leading to disruptions to the supply of drugs and devices that come from China. Can you tell us a little bit about whether you're worried about that and what can be done to conserve supplies of things like personal protective equipment and especially N95 respirators? What can hospitals do to continue safely, to care safely for patients if those supplies become more constrained?
I think this is an incredibly important point, and I think if we learn nothing else or nothing else happens to us, I think our response to this potential shortage of supplies should teach us something about how our healthcare systems work currently. So actually today at Emory Hospital, we just sent out guidance on the use of N95s. It involves reusing the masks for yourself, so you don't use it once and throw it away. You need to reuse it for yourself, except if certain parameters are met. We are also trying to implement, this is a very granular reality, but since I live both in the clinical world and the clinical laboratory world, one of the things we're trying to do is accelerate our ability to rule out people for tuberculosis. And so that's a very mundane and granular thing to maybe talk about on this podcast, but that is something that is really important to think about how you can be innovative and creative locally and use your resources better. And so more rapid testing for respiratory viruses. We also, if we have somebody that we're concerned about coronavirus, we actually, if they can go home and be quarantined, we prefer that because that actually limits the use of personal protective equipment. So if you think about one of the ways we could really cripple our healthcare system and hospital systems, if this was to come to our shores in a much larger way, is by housing all of these low symptom or mildly symptomatic coronavirus patients in a setting where they have to be cared for in personal protective equipment. That alone will definitely diminish the supply dramatically. Whereas if you could cohort them in a safe community place where they're secure, media can't reach them, they're not. They also are closely monitored so that they don't break their quarantine. I think that that's an option that also saves personal protective equipment.
That it's really interesting to hear about that linkage between sort of your practices within the community and this being more about just the supply chain itself. It really is about sort of the overall management of the patients who might have that virus. Am I thinking about that right?
Absolutely.
Excellent. Let me talk a little bit about the U.S. airport screenings that have been happening. We know that there have been more screenings for the novel coronavirus to date than there have been for the entire duration of the Ebola crisis back in 2014 and 15. Can you tell us whether you think such screening is effective and why that might be the case?
Thanks. So, we have a lot more global travel with China, so that's why we're seeing a lot more influx of people that may be persons under investigation from that area as compared to West Africa, or for sure the Democratic Republic of the Congo, which is currently having an Ebola outbreak. And I would just say that my summary of this is screening in any form to me is better than nothing, right? So I think not doing airport screening and not trying to figure out a way to kind of limit its spread into the United States, to me would just be a more passive response to this situation. I think it's always hard when you're doing screening and there's so many negatives to really understand the denominator of people that you are helping or are preventing illness or preventing transmission. But we do know that it's not going to be perfect, much like airport screening, just in general for security, I believe is not considered to be perfect. So I think we're doing our best to make sure that we have a system to effectively screen people so that if there is a concern, we at our hospital have evaluated people from the airport a few times and they've been negative, which has been wonderful, but I think it's also encourage people to self-report as well. Now, some people don't report because they don't want to be flagged positive, but I think we see an increase in self-reporting. So I think my summary statement would be screening in any form is better than no screening.
Great. One of the things that's certainly emerging as this virus outbreak continues is fear among the public. And there's a certain amount of normal fear that folks can have when a virus like this becomes an issue. That being said, the level of concern can certainly get escalated and potentially carried away. And sometimes that can be fueled by erroneous reporting that folks see in the media or elsewhere. So in the case of this virus, I'm hoping you can help us dispel some fears and sort of help folks understand what is sort of a rational set of fears around coronavirus.
Well, I would say we have a total of 29 people in the whole United States that are confirmed positive with coronavirus to date. So the likelihood that you're going to interact with anybody with coronavirus is very negligible to zero. I think myself on this podcast is the most likely person for among thousands to interact with these patients because of our previous history of having patients with Ebola, right? We may have them repatriated to our institution. But I think that we need to be more concerned about things such as flu. So we're in the middle of the influenza season, which has been particularly bad this year. We've had every year 10 to 60,000 people die of influenza, and we sort of don't give it a second shrug. We also don't get our flu vaccines because we don't think that they're needed and they're not 100% effective. But I would just say that we are sort of creating different logic for the coronavirus often in our rational approach than we do for other things that we do every day. And so there are ways to protect yourself even without purchasing masks. Again, what I've said earlier on this podcast, which is don't touch your face after touching a dirty public surface. Keeping your cell phone clean is a good idea. I've said that before. I think, thinking about your own hygiene, thinking about your own areas of transmission is a good way to reassure yourself that, I'm not in the states that have a patient. I'm never going to encounter a patient. But if I encounter somebody that's coughing on me or that's blowing their nose near me, I ask them to cough, especially if it's my child. I will tell them to cough more politely. But we can wash our hands and we can move away from people that are coughing or sneezing on us. So I think it's thinking about the ways that we protect ourselves without going overboard, and then realizing that there's something out there all the time, such as influenza, that we actually think very little of, but currently has more deaths per year than we have even cases of coronavirus in the world. So I don't know, not for everybody does putting a comparison against their current framework of understanding help, but that is one way to do it, is to frame it in the context of what we already know about influenza.
I think that's incredibly empowering advice to give to folks. I'm going to take a sort of a point of personal privilege and ask you a question that I don't think will end up on the podcast, but that I am somewhat interested in. So on somebody...
I've heard that before. And it's been on the podcast.
So I take public transportation every day. I take the metro to work. And obviously I have my phone out when I'm on the metro, listening to podcasts like this one, obviously. Yes. So if you have a personal device that you're using on public transportation, be it a bus or a subway, what's the best way to keep that clean?
So I don't, there's not been any literature review on this, right? So I just want to make sure that you don't take my advice and then say, it didn't protect me, because we've never done this case control intervention. But I personally, and I don't care if you put this on the podcast, it's fine. I try to wipe my phone down once a day. And so what I might recommend, and I have a box of lens cleaners, lens cleaner wipes that are individually wrapped, which I'm sure is not good for the environment, and I apologize. And I also purchase it from Amazon, which is also not good for our financial environment. So I also apologize about that in advance. But I have a box by my bed on my nightstand, which is totally pathetic, I suppose. And I just wipe my phone down before I go to bed. I also have a box at work. So if I'm rounding on patients, and I really tried for a long time to keep my pager off of my phone, so that I was never touching my phone in between patients, even though I do hand sanitize between patients. But I also keep some lens cleaners wipes. These can be for glasses or other electronic devices, not wet wipes. I'm talking about lens, like alcohol wipes.
Yeah.
So I tend to wipe them down when I just feel like I've been in a dirty place. So if I was touching a handrail in the metro and then touching my phone, I think all of that's fine. But what you don't want to do is then touch your face or rub your nose. And we have our hands in our face more than we think we do. And so what you might do is have a little hand sanitizer, like I do, hanging off my bag. If I get into a place that I feel like I've touched something that's dirty, it's not the end of the world to just hand sanitize. And I don't think I'm OCD about it. We'd have to ask people around me if I'm OCD, I guess. But I think that, doing something intentional every day to just wipe off a device that you're touching constantly is really important.
That's somewhat reassuring to me, because at home we have a box of those little mini alcohol wipes that I use on my phone just about every day when I get home. So
yeah, you're already doing it.
Good.
But you may get a parallel box at work, and after you've been on the metro in the morning, just wipe it down when you get to work.
All right. So I think we are close to the amount of allotted time. Let me just ask you, is there anything that keeps you up at night with respect to this outbreak of novel coronavirus?
Yes. So I was asked this question this morning. I'm at a emerging infectious diseases symposium in Maryland today. And so I think what keeps me up at night is to have something that is like coronavirus, like, for instance, MERS, that spreads like coronavirus or spreads like influenza. And so if that happened, it would really cripple our nation's supply of personal protective equipment. I think, unfortunately, there probably would be healthcare worker infection if it was so overwhelming. We saw that during SARS, like in some of the Asian countries. And so to have something like that is completely both virulent from a sickness standpoint, right? So like not a mortality rate of 2% or 1% like we're seeing, but a mortality rate like 50%, and easily transmitted like a coronavirus is, which is like a common cold virus. That's what keeps me up at night. So this is why people get concerned about pandemic flus. So like the H5N1 avian flus, which mostly transmit from bird to person, they tend to have a high mortality rate, but so far it hasn't been really yet proven that they can go person to person. But should they go person to person, that would be very concerning. If you want a visual on this, and I have no skin in the game, but the movie Contagion, for whatever it's worth, I'm not the best person to recommend movies, so I don't know that I like trust any of my judgment. But the movie Contagion is really good because it shows sort of like the burden of a respiratory pandemic and how it just cripples the whole, like everything, financially, personally, high mortality, people are isolated, no businesses are running because everybody's at home. I mean, I have to imagine that's what China is enduring. But it's interesting because it traces it back, spoiler alert, at the end, it traces it back to sort of where it all started. So I think that's, it's certainly a plausible scenario. And I think what we don't want to see is a virus that can cause lower respiratory tract infection, as bad as MERS, for instance, that can spread that easily.
Yeah. Dr. Kraft, thank you so much for taking the time to share your wisdom and your experience with us today.
Happy to do so.